Okay, our final disorder, personality disorders. These are enduring behaviors that impair our social functioning. Some people have questioned whether these are disorders or just quirks. The key thing that distinguishes between somebody who's just eccentric, we're allowed to be odd, right? This is, people vary. What distinguishes between an eccentric or odd person and a person who's disordered in this area is your difficulty getting along with other people, and very consistently unable to get along with other people. Other people don't want to spend time with you, whether it's a boss or a potential friend or a romantic partner. Difficulty getting along with other people in social settings. Okay, so there are different kinds of disorders, so I kind of clumped them by category. We have the anxious personality disorders. I gave an example. One is called the avoidant personality disorder. And basically the characteristic of anxious is that they're overall ruled by a fear of social rejection. They're just worried that other people are not going to like them. So what the avoidant person does is doesn't give other people a chance to reject them. The avoidant person rejects everybody else first. So they just sort of avoid social situations. They don't let other people get close to them. They don't share details about themselves that would help to seal a relationship. With the eccentric personality type, I give the example of schizoid, what you see here is some symptoms that are usually associated with schizophrenia, but you're lacking that full-on break from reality. So you have these odd characteristics. In fact, this category used to be called odd instead of eccentric. Eccentric is just another way of saying odd, I think. So in this personality disorder, you have people acting oddly, like they may believe things that aren't true, right? They might have delusions. They might, it's more common that a person with an eccentric personality type believes in things like UFOs, or that they've been abducted, or they'll spend their weekends hunting for Bigfoot and these kinds of things. Now, any of those beliefs by themselves does not qualify you as having a personality disorder, so don't get me wrong. What I'm saying is that it's one of the symptoms that can accompany the disorder. The dramatic category includes people like antisocial personality disorder, and the overall symptom in this category is a lot of attention seeking. There's a lot of self-centeredness present in this category of disorders, and behavior tends to be pretty erratic. It's hard to predict how the person's going to behave. I thought I'd give you an example of what the criteria looks like for diagnosing a disorder. I chose antisocial personality disorder. The DSM-5 is what psychologists or social workers or other people who might diagnose use to figure out what disorder a person might have. So you would come in to meet with your therapist and you experience, first off, what's called an intake, where you sit down and tell them basically what's the problem, right? And they take notes and try and figure out what category you seem to be falling into of disorder. If you're falling into a personality disorder, then they're going to start looking for which personality disorder. To be diagnosed with antisocial personality disorder, which, by the way, sometimes people call this sociopath, and sometimes they'll refer to it as psychopath. The diagnostic criteria is that you need to have a pattern of violating the rights of others since the age of 15. We give you childhood to not really understand social mores and behave. We talked about Kohlberg's moral ladder, and you really don't understand the conventions that go along with society yet when you're a kid. By the time you're 15, we're like, you should be getting with the program here and understanding that other people have rights and that you shouldn't be taking advantage of other people, hurting other people, things like that. So it's a pattern. One-shot deal where you one time commit a crime or one time hit someone or that's not enough. You have to have a pattern of violating the rights of other people since the age of 15 and across lots of situations. It's not something like that's family specific or school specific or something like that. Now you need to have at least 3 of these symptoms. Deceitfulness, which means you tend to lie. You disregard the safety of yourself or the safety of other people who you should be concerned about. You display aggressiveness, a failure to conform to social norms. You have a lack of remorse when you do something wrong and it harms someone else. You don't feel bad about it. Impulsivity and a failure to plan ahead. Irritability, and then irresponsibility regarding jobs, family, and money. So you have to have at least 3 of these symptoms to be diagnosed. Okay, so when we have, I'm going to go ahead and, I know we're recording, but I'm going to go ahead and I'm going to do a real quick demo of how, if you think you have any disorder, I should have told you guys at the very beginning, but a lot of times when you're studying psychological disorders, you start to display what we call medical school syndrome. And you'll, let's type in here, let's go with PTSD since they're offering it to me, and I did discuss that one. You'll start to think you have the symptoms that you've been studying. First off, beware the medical school syndrome. If you didn't think you had a disorder before you started listening to this or reading your text, you probably didn't have a disorder. So be really careful with that. The other thing I wanted to say is that if you are wondering and you want to see what the symptoms look like, did you see how I typed in DSM-V, because we're on the 5th edition, and then type in the name of the disorder? And generally you will find, here's from the state of Virginia, it looks like, here's dsm5.org, and you'll find a web page that'll show you the diagnostic criteria. Now I have to say, they were doing the transition from DSM-3 to DSM-4 when I was in grad school, and I'm not a clinical psychologist. I'm a cognitive psychologist who studies thinking and reasoning and stuff like that. So this is definitely not my specialty. And this seems to be taking its own sweet time, doesn't it? So when they made the transition to DSM-5, I noticed that they changed some of the formatting, and it's made it a little bit more complex for me. I was trained under the technique that the old one used. But here we have PTSD. Well, it looks like my Explorer is being the slow one today, doesn't it? Okay, there we go. So the criteria. Okay, so first off, every disorder has these criteria. Criterion A, stressor. Criterion B, intrusion symptoms. Every disorder will have criterion A and criterion B, and it'll tell you the things that are required for the disorder. And then you can scroll down some more. Oh, this one has more. Criterion C and E. Okay, that's good. Exclusion. You always have the exclusion component where you want to be able to exclude other possible explanations for the symptoms that are being displayed. And then you also want to, if there's anything else that is what they call comorbid, that's happening at the same time, dissociative symptoms, delayed expression. So you want to take note of anything that is, oh, and then we've got functional significance here. We've got the duration. So it's kind of organized a little differently than how I was trained. But you've got certain things that will always show up: the duration, the functional significance, the exclusion, and then anything that you're supposed to note as comorbid. They used to call it comorbidity. So if you ever need to look something up, and one of the really important things is this exclusion, because you want to say, okay, it's not due to this. I had a student once who came to see me because she thought her boyfriend might be bipolar based on what I had described bipolar disorder in class. So she started telling me the symptoms, and I said, that doesn't sound like bipolar. Let's look some other stuff up. And we were able to nail it down that it sounded more like it was tied to whether he had eaten recently and might have to do with blood sugar levels. Now, like I said, I'm not clinical, and I cannot diagnose, and I really cannot diagnose without him even here, right? But I'm just saying to her, there are things we have to exclude before we would go to a diagnosis of bipolar disorder anyway. And that's really, really important. You want to exclude other things that would be simpler explanations, things that might be easily treatable. we want to exclude what we can and then focus on what we need to be focusing on. Okay, so that's how you can look things up on the internet to find the DSM criteria if you need to be doing that. Now, how common are psychological disorders? This is the prior year prevalence of disorders in selected areas. You can see different countries listed along the bottom. Are they all countries? I've noticed sometimes they'll have out of nowhere like Beijing, right? Instead of having China, they've got Beijing, and they've got Shanghai on there. So there are a couple cities and then mostly countries. And the blue bars are people who have any mental disorder, and then the red bars are the people who have a serious mental disorder. And so you can see that if we're going to go with serious mental disorder, we're looking at less than 10%, and in most countries it's closer to less than 5%. So how common? They're fairly rare. That's why it's called a disorder. If it was really common, then it would be considered normal and common, and we wouldn't treat it as disordered. So fairly rare for people to have a disorder. And then now if we narrow it down just to in the U.S. and then the different disorders that I've covered in this chapter, you can see what percentage of people report these different disorders. Mood disorder includes both bipolar, major depression, and then there's actually other disorders that I didn't talk about. So if you take abnormal psych, you'll learn that there's a lot more mood disorders than just the two I mentioned. And then phobia of specific object or situation. You'll notice social phobia has been pulled out separately. But those are the most common ones. Then down below, you start to see the more rare ones, like OCD affects only about 1% of the population to be diagnosable, right? Schizophrenia about 1.1% of the population. So most of them are fairly rare. All right, well that pretty much concludes that. All right, well in the next chapter we'll talk about how to treat these disorders. So I will see you then.